I'm very pleased to introduce our next speaker. This is Dr. Gary Bloch. Gary is probably known to many of you in this room. He's a family physician with St. Mike's Hospital here in Toronto and is co-chair, importantly, of the Ontario College of Family Physicians Committee on Poverty and Health. To talk today about some of the work that he's involved with and its effects on health equity in Toronto, Gary Bloch.
Thank you. All right. Is this on? No. Okay. It's on. All right. Can anybody hear me? A little bit? Okay. If I was going to be truly equitable right now, I'd start with a cricket analogy, but I can't. I'm sorry. I want to cover a good bit of ground in the next 15 minutes, so I'm going to kind of jump into this. And as a starting point, I want to start with the assumption, let me see if there's slides up here. Oh. There we go. I'm going to start with the assumption that we're all working from the same vision here. And this is a vision of seeing the health world jump with both feet into addressing health inequities. And my story is about a slice of that pie. So I'm going to talk about the last 10 or so years of work that I've been involved in, which is focused on bringing health providers on board with the idea of addressing health inequities. And this story for me really has two starting points. One of them I'm going to spend no time on because Kwame in his warm-up act did this beautifully, which is that powerful body of health evidence, the evidence that links the social determinants of health like poverty with poor health outcomes. I'm going to assume that if you are here in this room, you are at least somewhat familiar with that evidence, but that is a huge driver for me. The other big driver are my patients. The stories that I hear and that all of us frontline service providers hear on the front lines of what we do every day. People like Vera, a 54-year-old woman I've known for years, who's been diagnosed with fibromyalgia, heart disease, osteoarthritis, and depression, who lives on Ontario Disability Support at about $1,100 a month in substandard subsidized housing where she routinely battles cockroaches, bed bugs, mice. She doesn't always feel safe walking in her neighborhood at night, and she has difficulty reaching the nearest grocery store. And Vera is someone that I've done everything I'm supposed to do for. I've ordered all the right investigations, prescribed all the right medications, referred her to all the right specialists and services. But despite that, over the years, I really have not seen much progress in terms of Vera's health. And the reason for that's pretty obvious to me, right? It's that she's suffering not just from physical illness and mental illness, she's suffering from social illness. And that's something that I have not been trained to treat. And so the rest of this story is going to be about my path to thinking about how we can start to treat that social illness. Now, the other starting point I want to tell you about is a bit of a trigger for me. A trigger, I should say an eye-opener is probably a better word. And this comes in the form of a campaign that I was drawn into, I think 11 years ago now, when I got a call along with a number of other health providers from the Ontario Coalition Against Poverty, a notoriously radical anti-poverty group. Many of you have heard of this group. And they wanted to get health providers involved in this campaign specifically to have us assess people for a supplement to welfare known as the Special Diet Allowance. And this supplement provides up to $250 a month in extra income for people who, at that time, a single person was making about $500 a month on welfare. Now, the health providers, when we sat down and looked at the regulations at the time, we realized that we could legitimately prescribe the full $250 a month supplement to every single person who walked into our clinics who was living on social assistance based on an evidence-based diagnosis of poverty. This is a little unusual and started to get some health providers pretty excited. The government, not so excited. They changed the regulations, stopped us from being able to carry out the clinics after a few months. But we were left with this nugget of an idea, this idea that we could actually directly treat a social determinant of health, a social illness like poverty, that we literally could prescribe income. And I was left with this vision, with this thought that maybe we could move beyond the few dozen providers who were involved in that initial campaign towards bringing the thousands of health providers in Ontario on board with this idea of treating social illness. So for the rest of my time, I'm going to tell you a bit about the path that I've come along in terms of structuring a program around this. And again, this program is still in its infancy, despite a decade's worth of work on this. So the first thing that we created, sorry, I can't see the slides, just to make sure it's in the right place. The first thing that we created was this, which is what's called a clinical tool focused on poverty. It's very simple. It's a 4-page fold-out color brochure that honestly looks like clinical tools that we receive in family medicine for conditions like diabetes, for heart disease. The difference here is that this tool is focused on poverty, on a social disease. And what it does is lay out a simple 3-step approach to dealing with poverty in the context of a typical frontline primary care appointment, the 10 to 15-minute appointments that I engage in most days of my working life. The 3 steps, very simply, first of all, screening all of our patients for their income. Second of all, taking that powerful body of evidence linking poverty with poor health outcomes into account as we go through our clinical decision-making processes. And third of all, actually engaging in a few simple but high-impact interventions to improve our patients' income. Things like having them fill out a tax form to allow them to connect with some of the high-impact government benefits that are out there to help support people's income. So, very simple, but in many ways, this approach and this tool has served as a bit of a game changer for us. So it's attracted the attention of a far wider range of health providers than we initially had involved in our work. I've literally presented to thousands of providers and trainees on this approach. It's also attracted the attention of big health organizations like the Canadian Medical Association that has become a pretty big champion for this work, the Ontario College of Family Physicians that allowed us to set up a committee on poverty and health to push this forward. Canadian College of Family Physicians has a social accountability working group. And other allies that have been working on this for longer than we have, like the Registered Nurses Association of Ontario. And over the years of kind of pushing this forward and as legitimacy has built, it's also set the groundwork for allowing us to start to look at other types of interventions into this work. And that's where I want to turn for the last bit of what I'm going to talk about today. So I am fortunate in that, I work in an institution that traditionally and through its mandate, St. Michael's Hospital has always sought to address health inequities. And for a department, the family medicine department within that institution, that has really been at the forefront of that work. And because of that, over the last 2 or 3 years, we've managed to put in place literally a full suite of interventions focused on directly dealing with the social determinants of health through what we do. And so I'm going to run through this quickly, because I know I don't have a lot of time, but just to give you a bit of a sense of what we've actually put in place in our health team to truly start to intervene in social illness. So the first piece of this is something that many of you are probably familiar with. This is the Health Equity Data Collection Project, really spearheaded by the Toronto Central LHIN. Now for us, the way we are collecting this data, these 8 basic social demographic questions, is that we have patients fill out a survey in our waiting room before they see us. By the time they reach my office, I can see the answers to those questions on their electronic medical record. I'm able to intervene right away if necessary. And then, of course, having this data in place allows us to understand who we're serving, to target our programs appropriately, and to evaluate them through a health equity lens. So absolutely foundational to the work that we're trying to do. The second piece of this program has been the creation of actual frontline health positions focused on directly dealing with social disease. In our case, we've put in place an income security focused health promoter. As of this week, we actually have 2 income security focused health promoters. And these people's job, their entire job, is to improve the income security of our patients. They do this through one-on-one case management. They do this through educating the provider group, as well as educating our patient population. They do this through community outreach and education, and they feed this up into higher level systemic advocacy on issues that get identified through this work. We've also been engaged in what I call intersectoral collaboration. And in this case, when I'm talking, that's obviously a big term. What I'm talking about here specifically is actually collaboration between other professions. And for us, that has meant collaboration with the legal profession. And so through a partnership between our hospital and our department and Legal Aid Ontario, we now have a full-time lawyer on site working in a medical legal partnership whose job it is to focus on the myriad legal needs facing our lowest income patients. We've also worked to move this, and I think this again is absolutely foundational, to improve our outreach and our responsiveness to the communities that we work in. And this is something that, unfortunately, is a fairly radical move for what has been a fairly traditionally structured healthcare team. So to this end, we've hired a full-time community engagement specialist, Sian, who I think is over there somewhere. And her job is to bring our community's voice into our program planning, our program evaluation, our implementation. It's also to bring our voice out into our community in which we practice, so to make sure there's a proper two-way conversation going on there, and to identify opportunities for collaboration on advocacy issues to do with the social determinants of health. The next piece of this program is really around what I've called creating new networks, new partnerships. And to this end, I want to talk briefly about something called the Ember Project, which was really spearheaded and created by Andrew Pinto, who I also think is out here somewhere. And this is a project that is focused on access to employment and access to decent work as a social determinant of health. And a couple of interesting pieces here. First of all, the creation of a tripartite advocacy network focused on this issue of access to decent work. The 3 partners, health service organizations, of which we are one, social service organizations that work with clients on the front lines around employment issues, and then work advocacy organizations like the Workers' Action Coalition. And these 3 partners coming together to identify and act on issues relevant to accessing decent work within our community of practice. They're also going to be developing a frontline intervention for our individual patients focused on helping them access decent work. The last piece of this program I want to talk about is work that we've done specifically looking at the frontline patient-provider encounter. Now, of course, this has involved the implementation of that poverty tool I talked about before, but what I want to mention here specifically is an intervention we've implemented focused on early childhood interventions and early childhood outcomes. We've put in place something called Reach Out and Read, which is a program that's been borrowed from the United States. It quite simply trains people on the front lines, in our case family doctors, to provide basic literacy education and hand out free books and literacy resources at well child and well baby visits. We now hand out 7 free books before the age of 5 to kids in our practice. And this intervention has been shown in the US to improve educational outcomes and literacy outcomes specifically for the lowest income and most marginalized groups that have access to the program. So a very exciting piece for us. Now, this is all being pulled together within our department by a central guiding group, a committee on the social determinants of health. This committee is not running all these programs, but its job is to try and find the crosslinks and try and bring this all together into a unified action program focused on improving health equity within our patient population. And all of this is paired with a very robust research and evaluation program, much of it being led again by Andrew Pinto, some of it by Nav Prasad, who's out there. And of course, with the goal of helping us understand how effective our interventions are, but also with the goal of helping us to disseminate these interventions farther from an evidence-based standpoint. So, if I was going to leave you with a couple of take-home lessons from all of this, I'm going to offer you 4 briefly. The first one is what I've called taking a stages of change approach to this work. When I say this work, I mean, again, this vision of bringing the health provider community on side with taking big level action on health equity. But a stages of change approach, of course, borrowed from the addictions world, says that we don't ask people to go too far too fast. We don't ask providers to go from doing nothing explicit on health equity to jumping out on the streets and advocating, yelling and screaming around big policy issues. We ask them to ask all of their patients about their income, get a sense of what's actually going on with their patient population, and then move stepwise from there. The second lesson from this, and this one I think is really important and really foundational, has been to keep our interventions tangible, to always have a very clear sense, especially for the providers involved in these, of what the outcomes are. And this means that when I see my patient go from Ontario Works to ODSP, see their income almost double, that I can absolutely see the impacts on that patient of that massive intervention, right? And this has been a large part of what has attracted providers to this work and what has kept them involved in pushing ahead with this. The third take-home lesson, I'm not going to spend a lot of time on this because I think the makeup of this room speaks to the fact that we all understand the need for cross-sectoral partnerships. This means many things. It certainly means involving the people who are most impacted by the health inequities that we're talking about in every stage of planning these projects. And I will leave it at that. And the last piece is a focus on the evidence. And I can't emphasize this enough. This is the language that the health world uses these days. The evidence is out there. We base the planning of our interventions always in evidence, or at least as much as we possibly can. But we also focus on creating new evidence where there is none, and specifically creating evidence around the impact of the types of interventions into health inequities that we're talking about. So, I will leave it there. I was given a short amount of time, and hopefully I've given you a sense of what we're doing, and I look forward to the discussion.
Thank you very much, Gary. We've got time for 2 questions, so we're going to make these count. So if you've got a really great question for us, anyone? I see, sir, we're going to come to you, and then we'll go right to the back. So these are our 2, make it count for all of us. Okay.
Thank you for a great presentation, Gary. It was really great. It's a lot of the stuff that I've been working on also. One of the questions I wanted to ask you is, how do you see the future of this? Is there going to be a place, more places for people who are non-medical to be involved in healthcare? So not necessarily peer workers, but people who maybe from same culture or social economic background, being able to work within a health setting to help provide that health care. Because I think that's a critical component to sort of letting people move forward, which is what you're trying to do also. That's why you have the link now to employment, because I think that's essential. You've gone from OW to ODSP. Moving people back into the workforce is going to be imperative for people. We don't recognize often how important that social component really is for people. And too often we are given diagnoses through social workers or doctors that we're not capable of working anymore. And that is not true for most people. So I just wanted to hear your thoughts about how you see sort of the medical care evolving within the work that you're doing to bring people in who don't necessarily have a medical background, but the work that they could engage in to improving the health equity and health outcomes for their community.
Thanks, Mike. That's a really small question. Hopefully I can answer it in the next hour. I agree that it's absolutely essential, and I think that it is part of the vision where part of where I'd like to see us go. And we have started to put a lot of thought into how we can truly engage the patients we work with, the communities we work with, the individuals we work with, in every element of our service planning, our service delivery, our service evaluation. That said, we are working within many layers of very heavily ingrained traditional structures within the medical system that pose barriers to actually involving people from outside the health world in what we're doing. And I feel like I run up against these barriers all the time. I feel like the will is there. I feel like it will start in small ways, like making sure there's community representation and patient involvement on things like our social determinants of health committee or our diabetes planning group or these sorts of pieces. Would I like that to evolve into things like involving peers in frontline health delivery? Absolutely. I know this is being done in other settings. Community health centers, I think, are way, way, way down the line on this, way, way farther down the line than we are in more traditional health settings. But I'm starting to hear the language, the true language of patient and community involvement filter into a lot of what I do, which I think is really exciting. Right. And obviously, I mean, I should say, we, like in our partnerships, we've worked on things like creating joint educational sessions for medical students, for instance, which allow people to start really hearing stories in traditional healthcare learning settings. I'm hoping that will also lay the groundwork for being able to carry out this collaboration in the future.
Okay, we've got one last question. If you just step forward a little bit, then the other people at this side of the room will be able to see you and hear you as well.
I'm not sure if they could see me. I'm very short, but definitely could hear me.
Oh, there you are.
So it's Nawal Busaidi from Thorncliffe Neighborhood Office. I had a question for the previous speaker, but I could definitely direct it to you. Both of you have talked about the social determinants of health and its impact on immigrants and refugees. And working within Thorncliffe Neighborhood and Flemington with the largest number of immigrants and refugees and the lowest rate of health quality, how do you see the role of community organization in supporting the successful implementation of health equity and improving health outcomes for residents in those communities? Thank you.
So there's a lot of echo in the room. I think that, so I think your question is specifically about immigrants, new immigrants and refugees, is that right?
Definitely, yes, for the immigrant, refugee, children, women, and seniors.
Right. Yeah, I mean, I think there's obviously a huge role for the health world in working to improve, both our political approach to how we bring in refugees, new immigrants, and in making sure that these individuals stay as healthy as possible and are able to be as productive as possible once they come in. I mean, I think there's a great example in terms of the part of the campaign around accessing healthcare for refugees has been very strongly led by medical professionals, a certain piece of that, who have been able to carry out a very powerful piece of advocacy when it comes to challenging government cuts to refugee health care. And I think there's also been some great examples of health providers just going out there and setting up health resources for new immigrants and refugees, like free clinics in Scarborough and in the West End, and other examples of this. I'm not sure if that completely, I wasn't able to fully hear your question, so I don't know if that completely answers what you were getting at, but hopefully there's some pieces to work from there. Okay.
Gary, thank you very much for leading off these first of three talks right now. Thank you for your time.